Welcome back to day 2 of the UCL conference on mobile health and the evidence space. I'm Delia Lloyd from BBC Media Action. I'm one of the few, the powerful, the only small coalition of the willing who put this conference together along with colleagues from BBC Media Action, Umeå University, and UCL. And before I start, I just want to give a shout out to one person in particular, and that's my colleague Ed Futrell from UCL. Ed led our group, he's the chair of the conference, and really without him the whole thing would not have happened. So I think we all deserve, I think Ed deserves a round of applause. Right, so I've been charged with giving a sort of very quick distilled overview of what we took out of yesterday, which is impossible because if you were here, you know that we covered a lot of ground. So I really just pulled together a few top-line takeaways, my top 10 list, and I invite you all to contribute to those. My number one takeaway is that time is of the essence, so I will be very brief so that we can get on with the day's proceedings. A few points of order. The very first one is really why we convened this conference in the first place, and yet it bears repeating, which is that at the end of the day, right now, right here in 2015, we still actually don't know that much about how effective mobile telephony is for securing health outcomes in the developing world, because we still lack a substantial, rigorous evidence base. Now that's unfortunate in a way, given how prevalent mobile phones are as a form of communication in the developing world, and given the tremendous excitement that all of us and others share about their potential to change people's lives. But I would add two caveats to that evidence point, which is the first, that the amount of research in this field is growing astronomically. Our colleague from the WHO presented a slide yesterday. It was just unbelievable, the amount of journal articles coming out looking at mHealth, and someone, I think yesterday afternoon, referred to it as a tsunami of activity. I think I might walk that back to a wave. Pick your favorite metaphor from the sea, but I think it is a really impressive body of work. So we are around the corner from having a really substantial body of research to draw on as we talk about this stuff. And the other point I'd make on evidence is that in order to make the best use of that evidence, we had a number of pleas yesterday from scholars and editors in the room saying, when you publish your results, please remember to describe your intervention. Such a basic point, and yet so important. Because if we want to tease out what really worked in making mobile mHealth interventions useful in saving lives or reducing or improving maternal health or whatever the intervention is, then we need to know how they work, because that's, and to actually know exactly what about them works so we can feed that back to policy. So that's point one. Takeaway number two, related to the first, is there are still too many pilots in this field. mHealth is a field that's dominated by an abundance of small-scale pilots. And one of the things that came out of yesterday's conversation was that instead of just continuing to do loads and loads more of those pilots, we want to think about scale and sustainability in our projects from the get-go, from the outset, so that when we launch a project, we're already thinking about those two things, which I'm going to come back to in a minute, rather than only when a project is completed. So we have to get beyond pilotitis. But the evidence problem is not simply a result of the fact that there are too many pilots out there. As one person pointed out yesterday afternoon, you don't need RCTs for parachutes. That's a clever catchphrase. What does it really mean? Really what it means is that if an mHealth intervention is not going to take significant resource away from another essential service, let's say using a mobile phone app to train health workers, is not going to come too much at the cost of getting antibiotics out there to fight off a life-threatening epidemic. So if you're not sort of violating that do no harm principle, then maybe the bar for what counts as evidence in mobile health interventions doesn't always have to be quite so high. I'm putting that out as food for thought. I'm sure others will pick up on it. And that brings us to takeaway number 4, which is the value of multi-method research. A lot of people yesterday, especially in the session that Peter chaired in the afternoon on evaluation strategies, talked about the importance not just of quant, but of qualitative research that gets in there and figures out why these things work. And that's because, as I was saying earlier, just echoing what was said by editors and scholars yesterday afternoon, we need to unpack why it is. It's not enough to have the results of your RCT or your regressions or whatever it is. We need to unpack what it is about the intervention that actually led to the positive or negative health outcome. To take the case of the India case study we did yesterday about recording childbirths. Was it the toll-free hotline? Was it the SMS? We need to know, because that's the thing we're going to look at to replicate and take to scale later on. So let us, by all means, unpack your theory of change and figure out which bits of the services embedded in your intervention really matter. And to do that, to paraphrase someone yesterday, we need anthropologists doing this work to get at those nuanced contextual factors as much as we need the epidemiologists in the room, with all respect to them. Moving on. Another big point that came up yesterday in Garrett Mell's presentation from the WHO was the growing salience of integrated approaches to mHealth. The idea here is that there's a growing understanding in the research community that health system challenges, like, for example, encouraging facility-based delivery, are affected by all kinds of things that range from transportation to education to supplies. And as a result, there's a growing demand for interventions that don't just do one thing, but that can tackle multiple aspects of health system problems simultaneously. So you need a phone, a mobile phone platform or device or intervention that lets you telephone an ambulance when there's a medical emergency, but also enable the health system worker to check for symptoms, register patients, order supplies. And a really nice example of that one-stop shopping model was the Tanzania example yesterday that our colleague described in Zanzibar from D-Tree International. That was a really interesting platform that she actually showed us the dashboard and how you could do a whole bunch of things at once and track them, including the financial piece, which was really interesting. But of course, a lot of yesterday came back to the fundamental point of sustainability and how do you build that. And we got a lot of ideas on the table, so I'm just going to rattle through a couple of them. One of the key things I think that a lot of people emphasized, and it was interesting because it came across all different kinds of interventions, was the importance of having a partnership with the government from the beginning, building that kind of buy-in and stakeholder interest from the government from the very beginning, particularly with the Ministry of Health. And the emphasis here was not just about getting mobile phone interventions integrated into national health plans, though that's important. It was actually about working with governments to identify the health problem they're facing, who the audience, the target audience is for that health problem, and then working with them to see whether, not how, but whether, in the first instance, mobile phones can help solve that health problem. Stated somewhat differently, we want to think about governments not just as part of the, not just an element of the supply side of these interventions to help us take things to scale, but on the demand side, to think about identifying what's the problem we're trying to solve in the first place. Another part of sustainability, working with the private sector, seems obvious, but we need to do it again from the beginning, not at the end. Many of you may have heard my colleague Sandeep present our Mobile Kunji work in India, which is a job training, a mobile-enabled job aid program for community health workers. One of the reasons that project has worked so well and has been taken to scale is because our program designers went to all the leading mobile phone provider companies in India, the top 6 or 7, and negotiated with them repeatedly, with a lot of engagement over time to convince them that it was in their interest to subsidize the telephone rates so that the health workers could call in for the service and get the training in the first place. They got that buy-in early on because they knew that you had to convince the private sector to support this, to get it to scale, and you had to get them to start thinking from a commercial standpoint that there was a lot of money to be made by tapping into these rural households, even poor ones, because they were all holding a handset. So, courting the private sector, by which I really just mean getting their buy-in, getting them to see that this is in their interest too, is a win-win for everybody. and a crucial part of taking things to scale. And finally, as long as we're talking about stakeholders, let's not forget the people who are affected by these interventions. We need to embed mobile phone interventions in society at large, in the populations. The Minister of Health from Ethiopia talked about Model Families program and how the government there is figuring out a way to reward families for adopting healthy behaviors and implementing healthy behaviors. And he talked about the related model neighborhoods and model communities. The important thing, there are lots of ways to engage a population, but the important thing is to recognize that people aren't just passive recipients of information in these interventions. They can be agents of change. And so we need to make ordinary people feel invested in these interventions as well, because that's a really crucial way of anchoring what we're doing in anchoring these interventions in society so that they last long after we've left the scene. Which brings me to possibly the most important stakeholders that we need to get on board with interventions. And this really stood out yesterday across all contexts, countries, levels, that we really need to get community health workers on board and give them a stake in this process. Why is that? Well, it's obvious in a way because in all of these countries, they are really the bread and butter, the backbone of these healthcare delivery systems. Anthony Costello in his opening remarks talked about the need to think about where technology meets relationships. And my colleague Sophia Wilkinson talked about the importance of mediated services, ones where you have content on a mobile phone, but that there's a discussion around it. Well, who leads that discussion? Obviously, it's the people on the front line most of the time. And precisely because the community health workers are the ones who are embedding, in many cases, that relational aspect of these interventions, we need to incentivize them to care. You might pay them more, one option, but it's not just about money. Sometimes the incentive to care comes from the training they get because it's part of upward mobility for them within their career path. Or maybe it's the self-confidence they get from having a supervisor at the other end of the phone who's coaching them through what they need to do. In one case in Africa yesterday, it was the fact that they got to keep the kit. They got to own the phone, and that gave them a literal sense of ownership in the project. It doesn't really matter, but the point is to get these guys on board because they're crucial to making these interventions work. And the story, one of the stories I loved yesterday was the Kenya example of the community health workers who were so invested that they went off and created their own app at the end because they wanted to carry forward. Now that's sustainability. Last point, I want to end on a high note because we started with the lack of evidence or the dearth of evidence, which is that the technical barriers to entry in this field aren't as high as we might imagine. There was an interesting conversation yesterday in the last session about how long it takes to train a healthcare worker on any of these tools, and the answer tended to be not as long as you think. Using a smartphone takes maybe a day or two longer than an ordinary handset. Yes, you need to go back and reinforce that training more quickly, but once these workers or these individuals learn how to use the smartphone, they use it more. And my colleague Sandeep also pointed out that age doesn't have to be a barrier to entry. In India with our mobile kunji, it was often the mother-in-laws and other people of a sort of older generation who really do make a lot of these crucial decisions around healthcare in families, who weren't opposed to taking on technology. To the contrary, they were the early adopters. They wanted to figure out a way to use technology to save lives. And that's a really hopeful story, regardless of what technology you're using. So on that positive note, I'm going to cede the floor to Ed, who's going to introduce our first speaker. Thanks.